Right, so we're going to start lecture 8 today. We're going to be talking about some major hematology tests, and those include the erythrocyte sedimentation rate. Some of you guys might have heard that term, the ESR. That's what that stands for. We're going to talk about our hemoglobin determination. We're also going to talk about the hematocrit and our indices, all right? Remember the MCV, the MCH, and the MCHC. All of those are calculated values. All right, so if you have ever heard of the erythrocyte sedimentation rate, it's very important that you guys understand it is only a screening tool. It is by no means can ever be diagnostic, okay? Because there are so many conditions that cause inflammation, and anytime inflammation is present within the body, that ESR is going to be increased. All right, so oftentimes you can't even really establish a baseline because your normal range is 0 to 20. So to have an ESR of 0, I mean, that indicates that there's probably not any inflammation present, but for females that have an elevated ESR, it doesn't really tell you anything. Physicians love to order this test. I'm thinking reimbursement might be pretty good for this test because you will do it quite a bit in a hematology lab. However, with that being said, if there is some type of condition present, whether it be multiple myeloma, maybe if the patient has anemia or anything like that, then that ESR could be a part of the whole patient picture. Does that make kind of sense? Or, again, it's never diagnostic, okay? We kind of use it in correlation with other results. And then the hemoglobin measures the, your hemoglobin is carried within your red cells, and so we want to measure the amount of hemoglobin in the red cells. We will look at the hemoglobin and hematocrit very extensively when we are looking for anemias. Okay, so if a patient has a decreased hemoglobin and hematocrit, there's some type of anemia, and then we're also going to want to correlate that with our indices, what type of cells are present, size, and hemoglobin content, and then we can classify our anemias. Okay, so we'll look at these indices very extensively. All right, so the erythrocyte sedimentation rate, again, non-diagnostic, non-specific, could be increased in several different conditions. And so what you want to do, you're going to take your anticoagulant blood, so your EDTA sample, and it's these columns. I thought I had a picture. So there's two different methods. If any of you guys already have some lab experience, you might have done this already. This is one of them. So you have these glass columns here. You just fill it up with blood, and what's going to happen is you're going to let the blood sit undisturbed for 1 hour. So we're measuring the rate at which these red cells fall out, and it's reported out in millimeters per hour. All right, so that's the principle behind the ESR. And we're going to talk about what causes the cells to fall out. Right, so what happens inside that tube, the red cells are close together. And I don't know if you guys have ever heard of the zeta potential before, but each red cell kind of has a negative charge around its membrane. So if you think about the red cells and negative charge, they kind of naturally repel each other. So it's not very normal that the red cells like to come together. When there are factors present that interrupt that zeta potential and allow the cells to come together more quickly, they naturally come together, they will form rouleau. You guys remember what rouleau looks like, the stack of coins? So anytime that zeta potential is interrupted, those cells will come together, they will rouleau, and they will fall quicker, all right? So that increases our ESR rate, okay? So you can think of it as the cells falling out, the cells settling, however you want to describe it. So the exact definition of our ESR is actually the distance in millimeters that those red cells will settle in 1 hour. It's very important that you guys understand this. So the amount of fallout, so the rate at which those cells rouleau and settle, is directly proportional to the cell mass, right? And we're not thinking about the total amount of cells, we're thinking about the size of the cells, all right? So if you have large cells present, macrocytes, then you're going to have an increased ESR. If you have microcytes, small cell size, you're going to have a decreased ESR, right? So it's directly proportional to the red cell mass, inversely proportional to the plasma viscosity. And again, normal red cells naturally repel themselves, so they don't really like to form rouleau. But the longer they sit, the more that zeta potential breaks down and they will settle. So what can interfere with our zeta potential, that cloud of negative ions around the red cells? Any type of condition that causes an increase in proteins, acute phase reactants, any type of inflammation such as osteoarthritis, rheumatoid arthritis. If those patients are currently having a flare-up of those conditions, their ESR value is going to be very increased. And again, once that zeta potential is broken down, the cells will be able to rouleau and fall quicker, and they will have an increased ESR value. Anytime you have increased fibrinogen, fibrinogen is an acute phase reactant, any type of increase in proteins, especially multiple myeloma. Multiple myeloma patients are known for having a very increased ESR value. And also other types of leukemias, usually other types of cancer, they will all have an increased ESR value just because of their body's response to that condition. It'll cause them to have an increased ESR. And then the presence of anemia will also result in an increased ESR. And I want you to think about why that is. If you think about conditions of anemia, what do we know about anemia? Have a decreased amount of red cells, right? And then you'll have an increased amount of plasma. What's present in our plasma? That's where your proteins are, right? So if you have increased plasma, excess of proteins, there's more proteins reacting on those cells. That zeta potential is going to be broken down quicker. Therefore, you're going to have an increased ESR rate. All right, so that's the opposite of polycythemia vera, where you have an increased red cells, all right, not a lot of plasma. All right, so your ESR is going to be decreased in polycythemia. Okay, does that make sense? And anytime you have an altered red cell shape, sickle cells, they cannot rouleau, right? They can't stick to each other, so they will have a decreased ESR. Spirocytes, because their membrane is altered, they cannot rouleau, so that will result in a decreased ESR value as well. All right, so here's your normal values. Have some variance among female versus male. Remember, your females are allowed to have a little bit higher ESR, 0 to 20, and always remember your units. It's millimeters per hour, okay? So 0 to 20 millimeters per hour. And then for our males, it's about 0 to 15 millimeters per hour. All right, so notice you have a 0 in there. So if you have a ESR of 0, you can't really say it's a decreased ESR value, right? Because it's 0. So that's kind of why this test is not really diagnostic, okay? All right, so there's two common methods that we will use in the lab, and you guys will actually get to do this in a non-B lab and an upcoming lab. The first one is the Wintrobe. This is the old method. You use a 100 millimeter column. It's a shorter lengthened column. Some people say that it actually provides increased sensitivity in detecting mildly elevated ESRs. Versus the Westergren, it is a longer column, 200 millimeters, and it is considered now the standard. It's the reference method. Most clinical laboratories are using the Westergren method, and you guys will get to see this in lab. I wish I had the columns with me. I would show you the difference today, but I don't. But in lab, you guys will get to see this. There's even some automated methods. I think I have a picture. So here's the Wintrobe. Here's your Westergren right here. See how it's a 200 millimeter in height column. And then here's an example of your automated method. You still have to load your Westergren tubes, but it uses infrared reading to measure the rate of fallout in the red cells. So where our manual methods take an hour, right? Because that's how we report it out, millimeters per hour. The infrared reading can be done in 20 minutes. All right, so it does significantly cut the time of this test. And you guys will get to see this. This is the SETI-PLAST ESR measurement. You guys will get to do this in the non-B lab as well. All All right, so there's always some interfering factors, okay? So you want to make sure this test is set up appropriately. If you guys notice in the Wintrobe method, this is actually a little vertical rack, and these columns sit in the racks. If you can see them right here, the columns are in there, right? Notice that they are perfectly vertical. If you have any variance, maybe that tube is tilted a little bit, it could falsely elevate your ESR, meaning that those cells are going to fall out quicker than they normally would. Okay, so that's an interfering factor. You want to make sure that it's perfectly vertical. Temperature is a huge factor as well. If you have, let's say, your laboratory, maybe the air is out and it gets abnormally hot. So if you have an increased temperature, that will falsely elevate your ESR as well. On the other side of that, if your lab is abnormally cold, then it will falsely decrease your ESR value. You guys will actually get to set up several ESRs in the lab. As you are pipetting blood into those columns, some of you might have some bubbles that form in your column. Just be aware that if you have bubbles within that column, what's going to happen? Are your cells able to rouleau? Are they touching each other? Is that zeta potential able to break down in that rouleau form? No, so it could falsely decrease your ESR. And then again, any type, yes, sir.
A question for you tomorrow on temperature, right?
Mm-hmm.
It seems to me like there's probably going to be a lot of variation in temperature. So is that something that gets reported, like the temperature of the day that I had?
So, and actually that is something that your lab will monitor on a daily basis. You will have an ambient temperature thermometer to test. Yeah. And so that'll be part of your daily QC, monitoring that temperature. And we'll do that in blood bank, especially because we're very temperature dependent. And then other labs too, you have to record your ambient temperature. And remember, I already mentioned this, anytime there's abnormal shapes, that will affect how well those cells can rouleau. Spherocytes and sickle cells will not rouleau. And so then you're going to have a decreased ESR. If you don't use the right anticoagulant, okay, so we're going to use our EDTA samples. If for some reason you use sodium oxalate or potassium oxalate and heparin, that will affect the red cell membrane, all right? It's going to cause them to shrink, and then it will falsely elevate your ESR, all right? So using the wrong anticoagulant, all right? And then your concentration of anticoagulant too. You want to make sure that tube is properly filled so it won't affect our ESR. That really comes into play because there is a disclaimer with the Westergren method. Now, I said we use EDTA, but when you guys do the Westergren method, you'll actually see it has these little, containers right here. It has sodium citrate in it. And so when you take your EDTA sample, you're going to add a ½ ml of patient sample into these little tubes right here. And that gives you the perfect anticoagulant ratio to sample. So that's kind of where that comes into play as well. Again, but these will already be added to you. You have to make sure you add the appropriate amount of sample. So how that works, your anticoagulant is already in here. You add your sample, and then you're going to forcefully push the tube down into this little vial, I guess you would call it. All right, you guys will actually get to do that, so it'll make a little more sense when you do it. And then the action, the force that you do is going to push that blood up into the column. Right, and I mentioned this too, you can't really have a truly decreased ESR value because your normal range is 0. So we really only look for increased ESRs. Another reason why it's not diagnostic is you can't differentiate certain conditions. Let's say bacterial and viral infections, both could have an increased ESR. Rheumatoid arthritis versus osteoarthritis, both will be increased, and your ESR will cause increased ESR in both conditions. And then different types of malignancies such as multiple myeloma and other leukemias, you'll have an increased ESR. So it's non-differentiating, all right, it's non-specific. All right, so keep in mind, we also mentioned anytime there's presence of acute phase reactants. All right, so remember fibrinogen is an acute phase reactant. So if your patient has increased fibrinogen circulating in their plasma, they will also have increased ESR, and then hypercholesterolemia. All right, so if your patient has a high cholesterol, it will also have an increased ESR value. Always remember that anytime there's a form of inflammation present in your patient, that ESR is going to be increased, okay? This chart is in your textbook. If any of you guys, it really kind of outlines which conditions would have an increased ESR and which ones would have a decreased ESR. All right, any questions about the ESR before we move on to our hemoglobin concentration? All right, so we will look a lot at our hemoglobin value when we start classifying our anemias. It is the best measure of anemia. We want to know how well are our red cells functioning, all right? Their function is to carry oxygen. Hemoglobin is needed for iron, and then iron will bind to the oxygen, okay? In the hemoglobin structure, I think I've mentioned this a little bit before, but it's actually composed of 3 primary units. You have your protoporphyrin ring, it's composed of 4 polypeptide chains, and then it also will be composed of iron. And we'll talk a lot about that. We have a future lecture coming up on the hemoglobin molecule. And then again, the function is going to carry oxygen to the tissue and bring CO2 back to the lungs. All right, so how do we determine our hemoglobin? This is whether you do it manual or automated. The method is the same, and it's termed the Sion met hemoglobin method. And it's going to measure, and we're going to talk about some different forms of hemoglobin. It will measure all forms of hemoglobin except sulfate hemoglobin. And that hemoglobin, sulfate hemoglobin, is just when a sulfur molecule is incorporated into the hemoglobin molecule, making that hemoglobin incapable of binding to oxygen. Okay. If you have an overexposure to antibiotics or a lot of pesticides, that's when that sulfate hemoglobin might form. But there's also oxyhemoglobin, carboxyhemoglobin. All of those are still measurable using the met hemoglobin. All right, so what happens inside? Any of my chemistry people in here will love this. We're going to talk about a chemical equation here. This is how your met hemoglobin is determined. So you have your ferrous hemoglobin, all right, it's bound to iron. It is going to combine with potassium ferrocyanide right here to form your met hemoglobin. All right, your met hemoglobin is going to be in ferric state, and then it is going to combine with potassium cyanide to get your Sion met hemoglobin. Okay, and remember, through this process, the cells are already lysed. All right, that cells have been lysed, that hemoglobin has been released, and this is the chemical equation occurring. And this is manual or automated. It is the same. So that just kind of lets you know how the Sion met hemoglobin is obtained. You might know what we can do with that now. The cells have been lysed. We have our Sion met hemoglobin. What does that tell us? Anybody remember Beer's law? The concentration of a substance, fluid, is directly proportional to the absorbance. All right, so we are going to use spectrophotometry to measure the amount of hemoglobin within the sample. With the implementation of automation, most labs, you'll probably never do a manual hemoglobin analysis. I've never done a manual hemoglobin determination. Maybe if you were in a underdeveloped area, would you do that? But you'd have to have access to those chemicals. All right, so if you were doing a manual determination, you would develop the standard curve. So you would have a commercially provided hemoglobin standard, and you would read it and then So you take your patient sample, you treat it, get the Sion met hemoglobin, then you're going to do your absorbance reading, and then dependent upon what your absorbance reading is, indicated here by the y-axis, you could compare it to your standard, and then you would have your hemoglobin concentration there indicated on the x-axis. Okay. And again, that standard would be commercially provided. It would be a known value. And so you could use your standard curve to determine your patient value. Does that make sense to everybody? And again, this is what is going on inside your instrument. So this is how your hemoglobin value is determined in the instrument. Does anybody know which bath the hemoglobin determination is made in the instrument? What determination do we need our red cells to be lysed? White cells, all right? So remember, to get a white cell count, we're gonna lyse our red cells. So in your instrument, you have a red cell bath and your white cell bath. In that white cell bath, those red cells are lysed. After the white cell count is obtained, there's a little cuvette. So your sample is going to drop down in the cuvette, and the spectrophotometry reading is going to occur there. And that's how it gets your hemoglobin reading. That's just a little further on. We have a whole section of automation coming up, so you guys don't have to know that right off the bat. But. Right, so I adjusted these reference ranges. If any of you guys have printed the PowerPoint out, they're a little bit different. Just keep in mind, as with everything else, males have a higher red cell count, right? And why do they have that higher red cell count? Androgen, their testosterone, all right? So because they have more red cells, naturally they're gonna have a higher hemoglobin as well, correct? So males do have a higher hemoglobin as well as newborns too. So your hemoglobin is measured in grams per deciliter. Yeah. All right, so with any of our hematology, there are some sources of error that you guys need to be aware of. And this is real easy if you can always come back to how the hemoglobin determination is obtained. Remember, we're using spectrophotometry. So we're measuring the amount of light that's being transmitted through that sample. So anything that affects the turbidity of that sample will alter our hemoglobin value as well. All right, so think of a really extremely high white cell count. Maybe the patient has leukemia, where that white cell count is 100, 200,000. That will make your sample very turbid. Okay, that could increase your hemoglobin value as well. Any one of your patients has a very high fat diet and they have a lot of lipemia present in their sample. That will also affect the turbidity of that sample. And then hemoglobin C and hemoglobin S, of course, they're resistant to the lyse. So during the hemoglobin determination, the chemical equation we talked about, they are not lysed. And so actually what happens, those red cells are not lysed, so they remain. And if you think about light trying to go through a red cell, it's going to decrease your transmittance, right? Because light cannot get through there. So it will affect your hemoglobin determination as well. Does that make sense to everybody?
I'm wondering how many different hemoglobins we're measuring. There's C and S.
Those are so those are your abnormal hemoglobins, and so they won't lyse like our normal adult hemoglobins, like hemoglobin A, hemoglobin A2, which we haven't talked about yet, but we will get to those. All right, so that's our hemoglobin. All right, so remember your reference method for hemoglobin determination. Anybody remember what it's called? Sion met hemoglobin. All right, that's a really good Board of Certification exam question. Okay. They probably won't ask too much detail about the chemical equation, but you do need to know that it's Sion met hemoglobin and that it is obtained spectrophotometry. Okay. And then you'll need to know what can affect it, all these interfering factors like lipemia, increased white cell count, hemolysis. I'll say that later. I don't want to get ahead of myself. Sometimes I do that. All right, so moving on to our hematocrit, also termed, you might hear this referred to as packed cell volume. And this is just expressed as a % of red cells in the whole sample. So if you think about taking your specimen, spinning it down, all right, so you have your red cells at the bottom, your buffy coat, and your plasma. The hematocrit is the % of that sample that is red cells, all right? That's our hematocrit. So we have a manual way to do a hematocrit, and that's using the small micro hematocrit tubes. Your automated hematocrit is always a calculated value, all right? So here's the automated. Remember in the 9B lab in your NCAPs, you have those micro capillary tubes? You guys are gonna actually use those to do your hematocrit. And so you just take a small capillary tube, you're gonna fill it with blood. And remember when you guys did the finger stick and you used those capillary tubes and we didn't put that clay in it like they did in the video? All right, so when we're doing our ESRs, we don't want that blood to spin out because we're gonna centrifuge. So we will use that clay. It kind of locks that blood in that tube, all right? Prevents capillary action from pulling that blood out and prevents that blood from coming out of the tube, okay? And then so once you centrifuge these micro hematocrit tubes, this is what you're going to get, right? So notice here's your clay. That's what stopped that blood. That's what blocked it in there. Here's your red cell layer. Here's your buffy coat layer. And then here's your plasma. This is what it's going to look like in our microhematocrit tubes. All right, so this is what you guys will use. And I have an old one. I'll pass it around. This is a microhematocrit reader. This is a very old one. It's kind of, I like to call it antique. So you guys will not be using this one. You guys are actually going to be using one like this. This is a more newer version. But what is important is you guys know how to read these. So as that's coming around, you'll notice it has a little plastic, this thing right here. This is where you'll load your microhematocrit tubes. And your clay line should line up right there. And then you're going to, you'll notice this plastic thing right here moves back and forth. You're going to line this 100% up with your plasma, okay? And then you always read where your red cell line is, okay? So then once you have your 100% line, so this one right here, lined up with your plasma, then you're going to move this knob on the right and you're going to line it up to where your red cell meet the buffy coat. You want to be under that buffy coat, okay? We do not include the buffy coat in our hematocrit reading. And I know that sounds kind of confusing, but you guys will actually get to do this and it'll make more sense then. And then this dial up here, if any of you guys have it, you see this dial at the very top, that will provide the % of hematocrit, all right? The % of red cells present in that sample, okay? And you're actually gonna do this test in duplicate. So you'll have 2 microhematocrit tubes per patient and they have to agree within 1% of each other, okay? Is that just for manual? Yeah. So this is just a different microhematocrit reader, but the same principle. See this little line right here? This is where you will line up your clay. So you want this line to be at the top of your clay. And then see this line right here? It rotates. And so you'll use this, you'll move it to the top of your plasma, and then you'll rotate the whole dial, this thing right here, it all turns, and then you'll put that on the top of your red cell layer. And see along the outer range here, that is your %. That would be your hematocrit value. Okay. I'm getting a lot of blank stares, but I know you guys will get to do this, and it'll make more sense.
Will we do it with both old and new?
That is the only one. Somebody actually gave me that one. I can bring that up to the lab and you can use it if you want to, but we will primarily use these round ones. All right, so that's your manual hematocrit. Most oftentimes, if there's any discrepancy between your hemoglobin and hematocrit, you might have to do a manual hematocrit. You probably will do this if you start working in the clin lab at some point. You'll probably do one of these. Your automated hematocrit is a calculation, like I mentioned, okay? So it's not a direct observation. It's not directly measured. It's a calculation based on your red cells and your MCV. So the number of red cells and the size of those red cells will determine the percent of packed cell volume. So you take your red cells, multiply by the size, your MCV, and divide by 10, and that will give you your packed cell volume percent. Do you guys need to know this calculation? Yes.
The MCV is what comes from these measurements. I'm sorry.
No, what's going around, that is your hematocrit reader. So that will be your hematocrit value, the manual method.
Okay.
All right. This is calculated.
Determining that number with two others.
Yes.
So you would tell us the MCV?
Yes, you'll have to have the red cell count and your MCV. So if I gave you those two values, you could determine your patient's hematocrit, right? Yeah. So what are some disadvantages to that automated hematocrit? Look at your calculation. What's the two values included in that calculation? Does anybody remember what happens in agglutination? What happens to your red cell count in agglutination? They're clumped together, so your red cell count is going to be falsely decreased. What about your MCV? Your MCV, those clumps are going to be counted as larger red cells. Your MCV is going to go falsely elevated, correct? So if we're using these two values in our calculation for hematocrit, then our hematocrit is also going to be effective, right? Does that make sense to everybody? So that's the number one disadvantage for automated hematocrit, because it is a calculated value. If you take a look at your spun hematocrit tube here, what happens if you did not spin your specimen appropriately? Think about what happens during the centrifugation process. Those red cells aren't going to be completely packed, right? So we could get a falsely elevated hematocrit. And also, if you don't spin it appropriately, there's going to be what we call trapped plasma. You're going to have some plasma that remain in your red cell layer. All right, so an advantage of hematocrit is you don't have that trapped plasma, or your automated hematocrit. You don't have that trapped plasma. All right, so in the event you suspect any spurious automated results, such as your red cell count is critically low, your MCV is abnormally high, then you might want to do a manual spun hematocrit. You guys will you'll have all the equipment, reagents, and well, you don't use reagents. You'll have the reader and everything, so you'll be able to do this. You'll do this quite a bit when you start working in hematology. What if for some reason you weren't able to access a vein on your patient? You could do a finger stick, right, and get a hematocrit. This is one way you could do a manual hematocrit, doing the spun. So that's kind of a advantage as well. Okay, so we have what we call a rule of 3. And what that means is your hematocrit value is 3 times the value of your hemoglobin. Okay, so you could take your hemoglobin value times 3, that should be your patient hematocrit value. With that being said, so you have a 3% range. So if your hemoglobin is 12, what should you expect your hematocrit to be? 36. So your hematocrit should be 33 to 39, right? So you have that 3% range, okay? If your rule of 3 does not apply, if you do not meet that rule of 3, let's say your hemoglobin is 12, but your hematocrit is 40, all right? You cannot report out those values. It has to follow the rule of 3, okay? Does everybody make sense? Does that make sense in everybody's head, okay? If for some reason you are doing the CBC on your instrument, your rule of 3 does not follow, then that would be an instance where you would do a manual hematocrit. We want to figure out what's interfering with that sample, okay? And then here's your reference ranges. So we're talking quite a bit about calculations today. We're also talking about reference ranges. It's very important that you guys know both of those. Okay. And there's variance, you guys. I know there's variance between, I'm trying to use what your textbook says as your normal ranges. So there might be slight variance in what the previous presentation says and what this one says. But just kind of know, like, if you take the mean value, so you know females should be around like 42 hematocrit. All right, so somewhere in there. You're not going to be asked what is a normal hematocrit range for a female. You don't have to know the exact number. I want you to be able to say, if a female has a hematocrit of 24, well, that she's like severely anemic, all right? And we want to know why. So that's kind of, because from hospital to hospital, you're going to have variance in your normal ranges. So students often get hung up on those normal ranges because there's variance. But don't get hung up. Don't like memorize those ranges. You should be able to know kind of like what your mean value should be, and be able to recognize when it's low or critically high. Does that make sense to everybody? Okay. All right, any questions on ESR, hemoglobin, hematocrit? All right, so we're going to move on into our indices. And this is our MCV, our MCH, and our MCHC. We will look at these when we start classifying anemias, whether the MCV be low and we have the presence of small cells, which will be microcytic, or versus on the opposite end of that, maybe our MCV is increased and we have macrocytic cells, large cells present. Or maybe our MCV is normal, so then we would have normal cell size. And then we'll look at the MCH and the MCHC to determine how much hemoglobin is within those cells, okay? So normochromic, if we have a central pallor in our red cells, normal amount of hemoglobin within those cells, that's normochromic. Hypochromic, if we have presence of microcytic cells, that central pallor is going to be very large, hemoglobin content is going to be decreased, that's hypochromic. And then hyperchromic, does anybody remember when we used the term hyperchromic? Presence of spherocytes, and you have an MCHC that is greater than 36%. Okay, but don't just look at your MCHC value because you could have a spurious result. Agglutination will give you a very high MCHC value. So you want to look at your peripheral smear. You want to make sure you have that presence of spherocytes. Okay, that's the only time we will use the term hyperchromic. We have an example coming up where we're going to talk about the presence of large cell size. A lot of students want to say, well, because they're larger, they have more hemoglobin content. But does anybody remember what causes large cell size? Macrocytic cells, but what it's associated with? Abnormal DNA synthesis, okay? So it's not really hemoglobin related, it's DNA synthesis, okay? All right, so mean cell volume, abbreviated MCV, this is the average cell size present, all right, within your sample. The higher the number, the larger the cell, okay? And remember, if agglutination is present, that would falsely elevate your MCV because all of those clumps are going to be counted as one cell, which would be classified as a larger cell. So the MCV is an automated value. It is determined by the size of the pulse. So remember, in the automated, think about what's going on in your back. You have two electrodes. As the cells pass through those electrodes, the voltage is interrupted. Each interruption is counted as a cell, and the size of that interruption determines the cell size, okay? And then that cell size is extrapolated on the histogram. I think I have a picture of a histogram. This is your red cell histogram, okay? And notice along the bottom here, it's in femtoliters. So our MCV is measured in femtoliters. And the normal range for our MCV is 80 to 100 femtoliters. All right, so the MCV takes into calculation your red cell count and your hematocrit. So you take your hematocrit divided by the red cell count times 10, and that will give you our MCV. So in this example, if your hematocrit is 45, divided by your red cell count of 5, notice that they just did the red cell count, right? You don't have to put 5 million, okay? And then times 10, you get 90 femtoliters. If you take a look at this red cell histogram, the peak represents the number of interruptions in your voltage, and that size, you have the most number of interruptions. Okay, so your peak is the most prominent cell population. Okay, so if you find your peak and then bring it down to your x-axis, that is your MCV. So this patient is probably about a little less than 100, maybe like 94. Okay, does everybody see that? What would happen to your red cell histogram if you had the presence of small cells? It would be lower, right? So notice that your peak, the predominant number of cells present in that sample is about a little over 50, right? So we're talking very, very small cells, right? Causes a left shift in that curve, that if you want to look at it like that. All right, so the smaller cells you have, it'll cause a left shift in your red cell curve. What if you had the presence of an increased MCV, and this is what your red cell histogram looks like? Notice the peak is shifted to the right. So you have a MCV of maybe like 110 on there. Okay, so you have an increased MCV right shift in that curve. There's something else we can obtain from this curve, and it's called the red cell distribution width, RDW. And it is obtained from the red cell curve, and it represents the size of peak. So you're taking from one side to the other, and that represents the variance in cell size. Okay, so and the RDW normal range is 11 to 15. So if you have an increased RDW or a very thick red cell peak, that represents that you have multiple cell sizes going on in that sample. All right, so the higher the RDW, the more anisocytosis present. Does everybody remember what anisocytosis refers to? Anisocytosis is the term for cell size. All right, so correlate your RDW with cell size. And that just means like the wider your peak is, the higher the RDW, the more anisocytosis you're going to have present in your sample. All right, take a look at this histogram. Notice that the peak is a little bit closer together. So you'll have a decreased RDW, meaning that all of the cells are pretty much the same size. You don't have much variation, not a lot of anisocytosis present. Okay. Does that make sense to everybody? Oh, look at this one. What's going on here? Two very distinct cell populations. This is characteristic of what you would see. Does anybody remember what type of cells you see in iron deficiency anemia? Not spherocytes. Possibly, yeah. But you would see microcytes, right? So remember, iron is needed for hemoglobin. And then if there is a nutritional deficiency and that hemoglobin can't be produced, you're going to have microcytes. Okay, so you have a population of microcytes indicated by this peak on the left side of that curve. You also have a predominant cell population that's a little bit right at 100 femtoliters. So you have another population of a little bit larger cells. Does anybody want to take a guess what those cells represent?
Maybe the smaller ones that
What type of cells are pumped out of the bone marrow? Reticulocytes. Okay, so think about what happens in iron deficiency anemia after treatment. The bone marrow has its nutrients required for red cell production, so it's going to start producing those red cells and pumping them out of the bone marrow to compensate for that patient's anemia. So you have the microcytes that were there prior to treatment, and now the bone marrow is starting to respond to that anemia, so you have the presence of polychromatic erythrocytes. You have two predominant cell populations. So this gives you that bilodal curve, that's what they call it. Right. Does that make sense to everybody? That's a very good example of where you would see two predominant populations after treatment of iron deficiency anemia. Or maybe after a patient has received a transfusion. You could also see maybe they had microcytic cells prior to the transfusion, and now you have their donor cells in circulation. So you have patient cells and donor cells. That would give you a bimodal peak as well. We have some examples in a little bit where we're going to look at the red cell histogram and correlate with our indices. All right, so that's the MCV. Now let's talk about your MCHC, your mean cell hemoglobin concentration. This is your average hemoglobin concentration in each individual cell, all right? And remember, it's a calculation. So you take your hemoglobin divided by hematocrit times 100 because it is a percent. So the MCHC is reported out in percent. So an example of that, if you had a hemoglobin of 15 divided by a hematocrit of 45 times 100, you have an MCHC of 33. So your reference range for that should be somewhere between 32 and 36%. And again, this value is always calculated, whether you have automated or manual. Yes, yeah, you will have to have those two values in order to confirm your calculation. So if I ever ask you on an exam, you will be given the hemoglobin and hematocrit. Most oftentimes what's going to happen is you're going to be given your patient's red cell, hemoglobin, and hematocrit, and you'll be asked to calculate the indices. Not only calculate them, but know if they're within normal range, right? Or abnormal. And again, we use our MCHC to determine the amount of hemoglobin, right? So we can look at this. Your MCH value will be decreased. Then we call it hypochromasia, meaning the amount of hemoglobin is decreased, versus hyperchromasia, when the amount of hemoglobin per cell is increased. And again, you want to make sure you have spherocytes present before you report the term hyperchromic. Did we do MCH? Did I completely skip over that? I did skip. Okay. I was wondering why, because MCHC. Okay. Let's go back to our MCH. Sorry about that. I skipped over it. Your MCH is your mean cell hemoglobin. This is the average weight of hemoglobin per cell. So if your MCHC is concentration, MCH is weight. It's a calculation. You take your hemoglobin divided by the red cell times 10, and that value is in picograms, PG. And again, it just kind of, MCH and MCHC go together. So we will always look at them when we are classifying our red cell size and hemoglobin content.
What was the normal range of the MCH?
MCH, like 26 to 34 picograms. right, so let's do some real world application between our red cell histogram and indices and what we see on the peripheral smear. All right, so notice in this example, we have our MCV measured by the peak of that red cell curve, and it's right at 90 femtoliters. Okay, so is that normal? That's normal. So what size cells would you expect to see on the peripheral smear? Normocytic. And notice that we have a red cell distribution width of about 14%. Is that normal? That's normal. So do you expect a presence of anisocytosis, variation in size on the peripheral smear? No, all those cells should be about the same size. And then we're given our MCH and our MCHC. MCH is 30 picograms. The MCHC is 33%. All right, so are those normal? Those are within the normal range. So what type of hemoglobin content do you expect on the cell, on the slide? Normochromic. So we have normocytic in size, normochromic in hemoglobin content. And remember, a good way to measure the size of your red cells, find a mature lymphocyte in a good area. That red cell should be about the same size as that nucleus of the lymphocyte. Okay. So just some examples of where you would see this. Normal, of course. Anytime there's an acute blood loss, because everything, all the nutritional values are there, they've just experienced a lot of red cell loss. So the bone marrow can start producing red cells that should all be normochromic, normocytic. All of our hemolytic anemias, such as sickle cell, G6PD deficiency, hereditary spherocytosis, they're producing normal sized cells, but they're being destroyed at a rapid pace. Those are normochromic, normocytic. So we do have some instances of anemia that are normochromic, normocytic. Okay. All right, take a look at this red cell histogram. Our MCV is 90, so a normal MCV, but look how wide that histogram is, how wide that curve is. And look at your RDW value of 18%. So you would expect some major anisocytosis present in this sample. An example of that would be following a transfusion or after treatment of iron deficiency anemia, or maybe even megaloblastic anemia too. All right, here's another example. Take a look at this red cell histogram. Notice that your MCV is 105 femtoliters. So what type of cells do you expect? Macrocytes, right? So large cells. Your MCH is 35. Notice that it is increased outside of our normal range. But our MCHC is actually normal, right? So it's 34%. Why is that? Does anybody want to know why we have large cells? Our MCH is increased, but our MCHC is normal. Not necessarily the distribution, but remember I said that macrocytes, just because they're larger in size, doesn't really mean that they have more hemoglobin content. All right, so we have the predominance of larger size, but they still have relatively the same amount of hemoglobin, some type of abnormal DNA synthesis going on there. Okay, so even though our MCH is slightly increased, our MCHC is normal. Okay. And this is very common, what you would see in liver disease. Liver disease causes macrocytes. Here's another one, our MCV. Notice that right shift in the red cell curve, right? So our MCV is increased at 110 femtoliters. Our MCH is 36 picograms. Our MCHC is 35%. But look at that RDW, 18%, indicated by the wideness of that peak. All right, so we do have, what does that RDW indicate? lots of different cell size. So anisocytosis is definitely present. What other predominant cell do you have based on that MCV? Macrocytes. And then notice our MCHC, we still have macrocytes present, but our MCHC is still within normal range, okay? Just so you know, anytime you have does anybody remember how many polychromatic erythrocytes the bone marrow produces on a daily basis? Somebody said it, say it loud. 1%, okay? So anytime you have a higher population of polychromatic erythrocytes, they're larger than the normal mature cell, correct? So it will cause a right shift in your red cell histogram, right? So they're going to be recognized as larger in size. So that will cause a right shift in the curve, increased MCV. All right, so take a look at this one. Our MCV is 70 femtoliters. So what type of cells do you guys expect size-wise? Microcytes, small in size. Notice our MCH and our MCHC values. Our MCH is 25 picograms, so very low hemoglobin content. Our MCHC is 27%. And if you were to look at I don't feel like this is a very good example. You have very severe microcytic hypochromasia. All right, so anytime, usually, remember, microcytic cells form when there's defective hemoglobin synthesis, all right? So anytime you have microcytes, usually correlates with hypochromasia as well. They usually travel together. You can say micro-hypo or hypo-micro, whichever one you want to say. You would see instances of hypo-micro in iron deficiency anemia, thalassemias, and we haven't talked about those yet, but just know those are some of the anemias that we're going to be discussing. So here's another example where we have an MCV of 75 femtoliters, so microcytes present, MCH of 25 picograms, MCHC 27%, so small cells, decreased hemoglobin content. Look at that RDW though, 18%. So we do expect the presence of anisocytosis. Look at your red cell histogram in this area right here. What do you think's going on right there? You guys remember what can cause a little bump in the left of the curve?
Red cell precursors getting into the peripheral blood?
Possibly, they're larger in size, but also like one of the major polychromatic erythrocytes. Yeah, they would be there too. So that's what you're picking up here. So this would be another example after treatment of iron deficiency anemia where that bone marrow is starting to pump out those polychromatic erythrocytes. And then maybe sometimes even after a transfusion, which looks different than our bimodal peak that we saw. That would be like a very severe case. And this is just and it's all about timing of when that sample was collected too. And then if you look in this example of the peripheral smear, see how the large central pallor, all right, so definitely decreased hemoglobin content. And then here's your mature lymphocyte. Take a look at these cells around it. They're all smaller in size, so microcytes. And when you guys are evaluating size and hemoglobin content, remember that you want to look at more than one field. You want to do about 10 fields to truly get an evaluation. Okay, and you're looking for the predominant cell type seen. So if most of your cells are normocytic, normochromic, that's what you report out, and then you might say slight anisocytosis present to differentiate all of those little maybe microcytes present, or maybe you have some macrocytes present. All right, so when you're grading your red cell morphology, you want to take the predominant cell population, and then you will note what else is present. I think that causes some confusion for a lot of students because they want to notate everything. Like, well, so I have some normal size cells, I have some smaller cells. Okay, but you're going to pick the predominant size, and then you're going to note what else you see. All right, so if you have majority normal, but some small, you would say normochromic, normocytic with the presence of slight anisocytosis. Okay, does that make sense to everybody? That's where some of this red cell morphology grading is very subjective. Okay. All right, and here's another one. Notice our MCV is 83 femtoliters. So on the lower end of that normal range, right? MCH, 38 picograms. What do you think about that? So remember, your MCH is hemoglobin content, the average weight of hemoglobin. So if you have an increased value, you might suspect that you have the increased hemoglobin in these cells, right? And then look at your MCHC, 39%. What's one cell type that can have an increased MCHC like that? Spherocytes. Okay, remember spherocytes? So if you look at the peripheral smear, spherocytes do not have a central pallor. They're small in size, hence our MCV of 83, right? So it's on the smaller size, right? So these are all spherocytes right there. And then look at your RDW. See how wide that red cell histogram curve is? Why do you think that RDW is so increased?
What is it?
Yeah, just throw something out. Lots of different sizes, okay? So remember, that's your indicator of anisocytosis. Because that red cell distribution is increased, you have your spherocytes, which are very small in size. What else do you have? Polychromatic erythrocytes, okay? So while your small cells is gonna drive your MCV down, those polychromatic erythrocytes going to kind of balance it out. And you guys don't know this yet, but hereditary spherocytosis is a hemolytic anemia. So you're going to have the presence of spherocytes, but then the bone marrow is going to try to compensate for those spherocytes being destroyed at a rapid pace. And so they're going to be pumping out polychromatic erythrocytes too. Okay, so in hereditary spherocytosis, that's what's going on. This is classic of what you would see in hereditary spherocytosis.
Aren't there two peaks like in that?
It's just not a very extreme case. It would have to be where you're getting two predominant cell populations to have the bimodule peak. This, you're saying probably the predominant is spherocytes, but you do have quite a bit of polychromatic erythrocytes too. This actually looks exactly the same in autoimmune hemolytic anemia, where there might be an antibody attached to those red cells, causing them to form spherocytes. They look exactly the same in their CBC parameters and on the peripheral smear, hereditary spherocytosis and autoimmune hemolytic anemia. Right, so I want you guys to get comfortable when you start looking at all of these CBC parameters. Look at your red cell histograms and correlate them with what you see on the peripheral smear. From here on out, we'll start doing that in lab. I think it's a very valuable hematology skill. All right, so in this lecture, we covered quite a bit of information. And again, it will make a lot more sense to you guys. We have an upcoming lab where we're actually going to concentrate on the ESR, the spun hematocrits, and our indices. Okay, so it'll make a lot more sense after that lab. All right, does anybody have any questions?
Are you able to tell if there's poikilocytosis from a histogram?
Poikilocytosis is variation in shape. So from the histogram, no. From the histogram, we can only tell size and if there's any variation in size from the width of that curve. For poikilocytosis, we would not be able to call that until we actually looked at the smear.